Hello, my name is James and I'm a current Foundation Year 2 doctor. Today I'm going to be talking about an interesting case I was involved in, but before that I wanted to introduce the topic of postoperative pulmonary complications. It is common for respiratory function to be impaired following general anaesthesia, and complications can include atelectasis, pneumothorax and pulmonary edema. PPC incidence ranges from less than 1% up to 23% in some studies, with 14 to 30% dying within 30 days post-op following major surgery. Moving on to the case, a 31-year-old female underwent an evacuation of retained products of conception at 8 weeks gestation following a miscarriage. Her past medical history includes pregnancy-induced hypertension and an undiagnosed autoimmune condition. During a previous flare-up of her undiagnosed condition, she attended the emergency department where she experienced a brief respiratory arrest following morphine administration. Treatment with naloxone demonstrated no clinical response and she began to breathe spontaneously after a short period of respiratory support. Pre-op review and bloods were satisfactory and the surgery and anaesthetic were uneventful. In recovery, her supraglottic airway device was removed. She was conscious, oriented, and vital signs unremarkable. Shortly after, she began slurring her words, became unresponsive, apneic, and started to desaturate. Bag valve mask ventilation was commenced, and an oropharyngeal airway was inserted but not tolerated. After 15 minutes of assisted ventilation, her respiration normalised. Throughout, she remained stable, with some myoclonic jerks noted. Pupils were equal and reactive. She was unaware of events and subsequently made an uneventful recovery. One theory for the cause of the patient's apnea could be explained by differing individual response to specific opioid analgesics. Fentanyl is primarily metabolized by the CYP3A4 enzyme, which is the most abundant isoform of cytochrome P450. The activity of this enzyme is known to display ethnic heterogeneity and inter-individual differences, with genetic polymorphism believed to be an important cause for drug metabolism variability. Allelic variants of the gene encoding this enzyme can reduce or inactivate its activity, leading to fentanyl accumulation and effect potentiation. This has previously been demonstrated in the literature, with case reports involving both tramadol and morphine use. Other suggested theories without merit include incomplete neuromuscular blockade reversal, despite not being used, and a functional disorder, as both respiratory arrests occurred in witnessed environments. This case highlights the importance of perioperative assessment in the identification and management of modifiable risk factors for PPCs. Protective management strategies have been shown to help reduce the incidence and severity of PPCs, helping to improve patient mortality and surgical outcomes. Physicians should ask about prior treatment with opioids to prepare for adverse effects and to exert greater caution. Patients with a history of excessive sedation to opioids may warrant genetic testing to rule out a metabolic defect. Thank you for listening.